Hello. 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 Good afternoon, viewers. I am Dr. DIPAYAN Nandy, Today we are going to discuss something about breast carcinoma. Uh, Apparently, the audience is primarily MBBS students, so I have kept the contents pretty basic. We'll be touching mostly all the topics: anatomy, pathology, treatment, diagnosis, everything. But we won't be going into the depths of everything because it would otherwise become a very lengthy discussion. Right. So I am not sure which year of MBBS you guys are in. So assuming that at least you have some basic knowledge of anatomy and pathology, we start this webinar. So let's first start with anatomy of the breast. So you must have all learned by now that breast is nothing but a modified sweat gland. It is an apocrine gland which is modified to produce milk in the reproductive phase of the female. So a gross cut section, lateral section of the breast, if you can see, so it basically consists of a lot of fat and supportive tissue, and the basically glandular tissue, which has a lot of alveoli or lobules and the ducts. So as marked here, as labeled here, you can see there are the ducts which lead to the lobules or the alveoli where actually the milk is produced. And then those converge into the nipple and the nipple areolar complex from which the milk is expressed externally. The breast has a lot of supportive tissue in the form of fat and fine connective tissue, fine bands, which are also called the ligaments of Cooper. Behind the breast is the chest wall, which basically main muscle is the pectoralis major muscle, as you can see here. And behind that comes the actual chest wall, which is the ribs and the intercostal muscles. Another very important structure which is not mentioned here is the pectoral fascia. There's a pectoralis fascia which overlies the pectoralis major muscle and lies between the breast and the muscle, which is a very important landmark during the time of breast cancer surgeries, where the fascia has to be included with the specimen when we remove the breast. Further, a little microscopic view, if we see on cutting the duct, you can see this is how the duct is a tubular structure which is being lined by normal epithelial cells, and there is a basement membrane. Please focus on this part, this B part, which is the basement membrane, which is very important as we will see in the further slides. So going ahead, another very important part for the anatomy of breast is the lymph nodes. You all know that every part of the body has a lymph node drainage. Depending on the site, it drains to a certain set of lymph nodes. For breast, that lymph nodes are mainly situated in the axilla. Right? So the various different groups of lymph nodes which drain the breast are primarily the axillary group of lymph nodes, which are further subclassified, which will come in the next slide. Beyond that, there is a infraclavicular group of lymph nodes and a supraclavicular group of lymph nodes. Basically, beyond the clavicle, which can be palpated from above the clavicle, these set of lymph nodes are called the supraclavicular lymph nodes. But as you can see, they're nothing but the continuation of the same chain of lymph nodes, which are starting in the axilla and going all the way up to the neck in the supraclavicular region. Another very important group of lymph nodes are these, the internal mammary or the internal thoracic lymph nodes. If you recall from your anatomy, there is an internal mammary artery or the internal thoracic artery which runs along the lateral border of the sternum. It gives various branches to the breast and is one of the major blood supply of the breast tissue. So along this artery, there are multiple lymph nodes which are called the internal mammary lymph nodes. So going further about the classification about the axillary lymph nodes. Axillary lymph nodes, when we examine clinically in a patient, depending on which part of the axilla you can feel the lymph node, they are divided into anterior, posterior, lateral, central, and apical. Anterior are the ones which you can palpate in the inner surface of the pectoralis major muscle. Posterior are those which are palpated on the surface of the latissimus dorsi, which is at the back of the axilla. Lateral are those which are felt on the upper side of the arm against the humerus. And when you go deep into the axilla, when you poke your fingers deep into the axilla, you first come across the central and then the apical group of lymph nodes. The same classification, when you look at it from a surgical point of view, it is defined in relation to the pectoralis minor muscle. Like we saw in the previous slide, there's a pectoralis major muscle which lies directly behind the breast, and beneath the pectoralis major muscle lies this small muscle which is called the pectoralis minor muscle. Based on the location of the lymph node, in relation to this, we can further classify the lymph nodes as level 1, 2, and 3. So, level 1 are the lymph nodes which are lateral to the pectoralis minor muscle. Level 2 are those which are directly below the muscle, and level 3 are the ones which are medial or above the muscle. So if you can correlate, you will see that more or less the anterior, posterior, and lateral group of lymph nodes are nothing but the level 1 axial lymph nodes. The central ones are, and maybe the apical, are the level 2. And mostly the apical, and which are also maybe called the infraclavicular ones, are level 3. So all in all, it's important to stick to one set of classification. For surgical and for oncological purposes, we stick to this classification most frequently, which is level 1, 2, and 3 in relation to the pectoralis minor muscle. So I think that should be enough about the basic anatomy of the breast. Going further, let us discuss about the pathology. Now, if we are to discuss the pathology of breast lesions in general, they can be benign and malignant ones. But again, that's a huge discussion and we cannot accumulate everything right now. So we'll focus only on the malignancies of the carcinomas of the breast. So the broad classification of breast carcinomas can be in two types, in situ and invasive ones. In situ is basically the carcinoma which is not yet breached into the basement membrane. As I told you in the previous slide, as you can see, the normal duct, which is lined by epithelial cells and has a nice membrane around it. In this part, you can see the duct has some abnormal cells, which are shown in some different yellowish green color, but still that membrane is intact. So in spite of having malignant cells, there is no breach of the basement membrane. Such a carcinoma, such a malignancy is called an in situ, as the word suggests. In situ means it has not yet come out of its normal natural place. So it's an in situ carcinoma arising from the ducts, then it is called a ductal carcinoma. Similarly, an in situ carcinoma which will arise from the lobules, the alveoli, milk producing glands, then it becomes a LCIS or lobular in situ carcinoma. Once the basement membrane is breached, they then classify as the invasive carcinomas. The invasive carcinomas again can be of multiple types, of which the most common is the intraductal carcinoma, which is nothing but, you can say, the DCIS, which has now breached the membrane and progressed further. So DCIS, which breaches the membrane, progresses further to form what is called the ductal carcinoma, infiltrating ductal carcinoma. Similarly, a lobular carcinoma is one in where the in situ lobular part has breached the membrane and spread beyond it. Then these are the various other subtypes which are not very common, which we'll come to later. So now let's proceed with the pathological discussion. Ductal carcinoma in situ. This is more common than lobular carcinoma in situ, so we'll just discuss it. As I told you, the basic thing is there are malignant cells formed from the epithelial lining of the ducts, which starts forming a carcinoma, but the membrane is not breached. For academic purposes, it is further classified into a comedo type, cribriform type, solid type, micropapillary, papillary, and mixed type. As you can see in these images, they're nothing but how the duct is filled by the cancerous cells. If it is filled totally, it becomes a solid one. If there are certain crypts available, then the spaces in between, then it's a cribriform. And if it's not cells, but some kind of colloid material is forming, then it's named as comedon. This basically are pathological classifications important for academic point of view. From the management point of view, either of these forms, if it's a DCIS, the treatment modality primarily remains the same, which will of course become later. Going further, as I told you, the same DCIS, once it starts breaching the membrane, it becomes an infiltrating carcinoma. So as you can see in this diagram, the cells have started breaching the membrane and coming out, so it becomes an infiltrating ductal carcinoma. Further, when these cells, they breach and enter a lymphatic channel, a lymph duct, that is when they can go through the duct and spread to the lymph nodes and go and involve the axillary lymph nodes. The things what we discussed previously the axillary lymph nodes may be affected by the breast carcinoma. Similarly, if it goes and involves any of the blood vessels, it can metastasize through the blood. The most commonly affected organs by metastasis from the breast are the liver, lungs, bones, and the brain. So that is the mode of spread through the blood vessels if it goes to distant organs, and through the lymphatics to the lymph nodes. Similarly, for lobular carcinoma, as you can see, it arises from the lobular part, and there is a breach of the basement membrane, and it goes beyond the membrane. So the more common types we have already discussed are the ductal carcinoma in situ, the IDC, and the ILC. The other types which have been mentioned here, they're nothing but variations of the infiltrating carcinomas. Normally, if you see a report, they're reported as IDC, NOS, or NST, that is not otherwise specified or no specific type. This is the most common type of ductal carcinoma. There are certain other types of carcinoma where, based on the pathological microscopic feature, the histopathological feature, they can be differentiated and labeled as different carcinomas like tubular or cribriform, medullary, mucinous, papillary, metaplastic. We're not going much into the details, but basically, depending on the histological picture, this is how they are defined. Like in the mucinous ones, there is more mucin or colloid producing cells, so which gives that picture. The papillary carcinoma, there are papilla or fronds of cells formed, which is more infiltrating type. The metaplastic carcinoma are ones where you tend to see cells which are not normally seen in the breast, but they can be seen in these tumors. Like sometimes muscle cells can be seen, or even squamous cells. Of all these, of course, the tubular, medullary, and mucinous ones, the importance of knowing this classification is the tubulary, medullary, and mucinous ones are usually better prognosis, less aggressive ones, and they tend to grow slower. But if the papillary and the metaplastic ones tend to be more aggressive, so we need to be more aggressive in our treatment when we deal with this histopathology. Another important part of pathology for breast includes the prognostic markers, which are the hormone receptors and the other biomarkers. The most important of these are, of course, the estrogen and progesterone receptors, which we'll see further when we discuss the treatment, that they play a very important role in the treatment of the cancer. The expression or underexpression of estrogen progesterone receptors has a very huge impact on the prognosis, how aggressive the disease is, how what are the chances of recurrence, what are the chances of metastasis, and everything. Similarly, another marker is the HER2/neu. It's a receptor on the epithelial membrane, which you must have learned in pathology, which is usually seen to be expressed in most of the breast cancers. And depending on their expression, again, the pathology changes. As you can see in the next slide, there is a commonly used table which shows the various permutation combinations of these markers being positive or negative. And depending on that, the prognosis varies. The luminal A type, or the ER/PR positive HER2 negative, is usually considered among the best or the least aggressive variant of the breast cancers. And having this report is a good sign for the patient, and also helps us be a little less aggressive with the chemotherapy, or maybe uh, control the doses of chemotherapy if we get such a report, especially with the low Ki67. Ki67 is nothing but a proliferative index. As you know, all malignant cells have a very high rate of proliferation. Compared to a normal cell, the malignant cells proliferate at a very high rate. So in that, this rate can be calculated, can be estimated by this marker called the Ki67, which is nothing but a protein which is formed during the cell division. So titrating the value, the amount of this protein, we can decide the proliferative power of the cell. And of course, as common sense, a low proliferative malignancy would be less aggressive, and a high one would be more aggressive, with more chances of metastasis and recurrence. So again, coming back to this the classification, luminal A, luminal B. Luminal B again is all the three are positive, and the basal type is also called the triple negative, which is considered among the poorer prognosis. And then there comes the HER2 type, where only HER2 positive, where ER/PR are negative. So these are the various ways which the pathological reports can vary for a patient of breast cancer. And this is how it can affect the treatment, which is, of course, we'll see in details later. So going further, let's discuss something about the risk factors or the clinical part of the breast cancer. So most common ones are the ones which we call the non-modifiable risk factors, factors which you are maybe born with, which we cannot change, but which predisposes you to the risk of malignancy, and hence it should be such patients should be uh, treated with more suspicion. Gender, of course, 99% of the cases of breast cancer happen in females, but males are not spared. 1% of the cancers are also breast cancers are seen in the male patients as well. There is breast tissue in the male patient, which may be rudimentary in some in cases of gynecomastia, it may be enlarged. But this tissue can develop into a cancer exact same way like a female breast develops cancer. The pathology, the treatment, everything remains the same, whether it's a male or a female. Gynecomastia, of course, is not a risk factor for CA breast. Next factor is the age. As you can see from this graph, increasing age is a definite risk factor for breast cancer, which you can clearly see as the age increases, especially above 70, the incidence of breast cancer goes very high. And nowadays, with the increased life expectancy, the geriatric population has increased. We have more and more ladies who are surviving beyond the age of even 80 years. And so that is why there's a very high incidence and a high chance of breast cancer happening in these set of patients. And any breast lump which is detected in a lady more than 70 years, any new lump which is detected in a lady more than 70 years, we consider it as malignancy otherwise, unless proved otherwise. The next risk factor, of course, are genetic factors. There's a difference between genetic cancer and familial cancer. Genetic cancers are those where your the gene itself has some mutations which predisposes you to having a cancer. There are multiple genes which have been studied, but the most common ones related to breast cancer are, of course, the BRCA1 and BRCA2, the BRCA1, BRCA2 genes, which have a very high, close to 80 to 90% chance of a patient having a breast cancer if they have these genes. Similar, another gene is the Lynch syndrome gene, or the HNPCC syndrome, if you know. So there are certain genetic factors which predispose a person to breast cancer. Again, there's a role of the race or ethnicity. It has been seen that there is seen more breast cancer is found more in the Caucasian or the white population, whereas in the Africans or the black population, though the incidence is less, they have a more fatal disease and there's more chance of having a mortality because of the disease in this population. The next risk factor would be family history. As I told you, family history and genetic is slightly different. A familial breast cancer may not have necessarily the genetic mutations which we discussed earlier. Family history means that someone in your close family in the blood relation has the disease in the past. It could be your mother, a grandmother, both maternal side and paternal side, a sister. Anyone who has a family history need not necessarily mean that that person will also have the CA breast. Like we talked about in the genetic DRCA1, there's an 80 to 90% chance of having a breast cancer. But if someone's mother has had a breast cancer, it does not mean he or she has the same risk. But the importance of family history is that these patients should be screened more regularly because they are definitely at a higher chance of having the disease than the general population. Then more the number of members in the family, the risk increases. So in those patients, what we recommend is to have a proper genetic counseling with the entire genetic family tree being made, and then the risk estimation, and accordingly the risk prophylaxis or the treatment can be started. The next factor is, of course, the menstrual history. I guess you guys are aware that breast cancer is primarily considered a disease of a hyperestrogenic state. So the longer the female is exposed to an estrogenic state in her lifetime, the more is her chance of developing the breast cancer. So that is why a person with an early menarche, an early onset of menstruation at a late menopause, that is the late stoppage of menstruation. So the longer the duration of active menstrual period of the female, there is a higher chance of her having a breast cancer. Another important factor is the pregnancy. Pregnancy in general is considered to be protective against breast cancer. So nulliparous women are more at risk, and women who have had an early first pregnancy are considered to have a lesser risk. Again, going by the same principle of the menstrual cycles, the pregnancy disrupts the hyperestrogenic phase, the estrogenic phase of the female's cycle, and thus gives some protective action against the development of breast carcinoma. Breastfeeding, we all know, has always been promoted as a protective factor. Absence of breastfeeding may not lead to breast cancer, but of course, breastfeeding has been shown to uh, protect from breast cancer. OC pills or the contraceptive pills, of course, nowadays we have low dose estrogen, high progesterone pills, which again have decreased the risk of breast cancer to almost negligible. And most of the contraceptive pills prescribed today are pretty safe. And unless there is some other risk factor or a family history or a genetic predisposition, oral contraceptive pills can be considered safe in today's age when prescribed by a practitioner or a gynecologist. Hormone therapy is when postmenopausal most of the time are used when patients have hormone withdrawal symptoms. There again, the dose of estrogen, if it can be minimized, the risk factors can be decreased. Other common factors, of course, are obesity. Obesity, we know, are responsible for most of the cancers, be it colon, pancreas, breast. All cancers have been directly or indirectly related to obesity. Similarly, is the diet, which by itself or via obesity can cause an increased risk of cancer. On the same lines are the addictions, most importantly, alcohol and smoking. All these are very well known and, of course, modifiable risk factors of breast cancer. Another important risk factor where there is a lot of confusion and a lot of research going on is which are the breast conditions which are actually precancerous. Please bear in mind a DCIS or LCIS, that is the in situ carcinoma, is not precancerous. It is already a cancer, right? So when we talk about a precancerous lesion, it is a lesion which is not yet cancerous but can convert into a cancer. Similarly, a simple fibroadenoma or a fibroadenosis is not a precancerous disease. It is now proved beyond doubt that a fibroadenoma does not convert into a malignancy per se. There could be a separate focus or a nidus of carcinomatous cells developing in a fibroadenosis part of breast, but they per se never convert into a malignancy. The two lesions which have been found to have a high risk of converting to malignancy are the atypical hyperplasias and the radial scars. Another risk factor is the breast radiation. Now, today, with the increased incidence of cancer and the increased use of radiotherapy for different breast cancers, most commonly the lymphomas and leukemias, then the childhood cancers, many of the children, the young girls, they're exposed to radiation as a part of treatment, which again predisposes them to develop a breast cancer in a later stage. So these are grossly the major risk factors or etiological factors which can lead to a breast cancer. Going further, let's discuss about the clinical features. In clinical features, the most common feature which a patient presents with always is a lump in the breast. The lump can be anywhere in the breast or it can be even in the axilla. Sometimes the breast uh, lump is small but and not detectable, but in the axilla you can find a big lump present. The other symptoms include the skin changes. Sometimes, especially if the breast is bulky, it is big, and there may be a small lump which is not evidently visible from the outside. But there are indirect changes in the skin which can lead to us to suspect that there can be some disease inside. So most commonly seen is the skin dimpling or the indrawing of the skin, a puckering of the skin. That especially when the patient raises her hands or moves her hands, we can see that a certain part of the skin is pulled abnormally in the breast. Sometimes that we can see the changes in the skin, that the skin can become red or erythematous, or sometimes there can be edema of the skin with small punctate holes, which are classically described as the orange or the pudy orange appearance, what you call the orange peel skin appearance. The next one could be how the changes in the nipple areola complex. Like we saw, the skin can be pulled in. Similarly, the nipple and the areola can be pulled in without an evident mass visible. So any change in the nipple areola complex is also a indirect indication of a breast carcinoma harboring inside. Another such symptom would be a discharge from the nipple, which could be a bloody discharge or a clean discharge. Bloody discharge, unless proved otherwise, has to be considered as a malignancy and treated accordingly. A clear discharge we may observe, and depending on the other investigations, can be observed. Sometimes milk discharge is also present, which of course in a lactating woman is normal, but in patients who are not lactating without a history of recent pregnancy, they should also be investigated. So again, going and discussing the same thing further, we should also always look for the subtle signs or subtle changes. As you can see in this first diagram, the left side breast is pulled up. The level of the breast is not the same. The level of the nipple is not the same. Even in resting position, this may be the only sign which can indicate that there can be some problem inside. It's very important when you're examining a patient to inspect properly before you start palpating. Inspect properly, compare the both breasts. They should be identical. Their levels should be at the similar, and the nipple areolar complex should also be in the same place. Another thing is there can be changes only in the nipple, which is also called the Paget's disease, where there is an eczematous changes only in the nipple areolar complex with ulceration and bleeding, but the underlying lump may or may not be there. So again, these have to be checked properly and treated accordingly. Discharge we discussed. Sometimes there may not be a spontaneous discharge. You may need to palpate and express the discharge by pressing the breast from various directions. Swelling, of course, not necessarily in the breast, as I told you, we have to see sometimes there's in the axilla. The lymph nodes can get enlarged first, or maybe if it's a bulky breast, you do not see the lump in the breast, but the lymph nodes are enlarged and you can take a look at those lymph node mass. Also, as we saw earlier, supraclavicular, above the clavicle, even that area could sometimes be the first presenting symptom. Again, because of fat, the axilla may be obscured and the patient does not feel it, or she cannot see it. But when the fullness in the supraclavicular region starts appearing, that is when the patient gets alert. And of course, there can be a lump and thickening of the breast itself, and changes in the skin, as we discussed, the retraction, puckering, and the pudendron changes. Nipple changes, nipple being inverted or retracted, change in the position, and a pain in the breast. One thing we should remember is usually malignancies, breast cancers are painless to begin with. The pain starts once they start infiltrating the skin or the muscles below. So a pain in the breast lump is usually an ominous sign. If it's an inflammatory breast lump which is painful, then it's a different story. But breast malignancy with pain is usually an advanced disease and needs to be tackled accordingly. If going in the same flow, I wanted to put this slide because all of you are medical students and eventually you will become doctors. And irrespective of that, whichever field we work as a doctor, we have a family, our friends, a society where we need to make them aware of these subtle changes happening in the breast. Everyone cannot always go to the doctor for a checkup. They don't go for a mammogram regularly, but this is one thing, self-breast examination, which can help the person to detect any change. As we saw in the earlier slides, a lump is not necessarily the only sign. There can be just be a fullness. There can be just be a change in the appearance, change in the skin. And these subtle changes can be appreciated by the patient herself if she is looking at it regularly. Right? So what is important is any female who's above the age of 40, preferably above the age of 30, they should always do a monthly self-examination. We have demonstrated how it is done. Usually it is better to do before or after the shower in front of a mirror in different positions with hands by the side, hands above the head, and hands on the hips. As we saw earlier, a change in the position of the breast can many a times make a lump or skin change evident, which on rest may not be visible. By these changes, they can be easily visible. If nothing is visible, then it's important to palpate the whole breast and axilla in a particular direction. It can be clockwise, counterclockwise, any clockwise, but all the quadrants should be palpated thoroughly, including the axilla. Similarly, the same thing should be done again in a lying down position because that helps us to press the breast against the chest wall and give a better palpation. And last but not the least, the nipples should be squeezed and seen if there is any discharge which is available. So a breast self-examination or a clinical examination which is to be done by us as doctors are practically the same, and these are the points which have to be remembered: are the position covering the whole breast, also the axilla, and check for nipple discharge. So once we have examined the patient and we see a breast lump or a doubtful breast carcinoma patient, we proceed for the diagnosis or the investigations. So what are the investigations? Classically, this is a diagram which has been given in the Love and Bailey Book of Surgery since I think almost 50 years now. So the basis has not changed. The basis of diagnosis of CA breast remains the same. It is a triple assessment: clinical, imaging, and pathology. Clinical means a thorough clinical examination and history taking, which we saw right now, that we have to check for all the risk factors, all family history, and of course a thorough physical examination. Imaging of any type, most commonly, most sensitive right now, of course, is the mammography, or we can also do a sonography or MRI, which we'll discuss later. And the third part is the pathology, which can either be a FNAC, that is a fine needle aspiration, or a bigger chunk or a core biopsy. Right? So triple assessment for breast malignancy is the gold standard even in today's day and age. So going with the imaging part, the main imaging, the gold standard now, of course, is mammography. As you can see in this image, the breast is pressed between two plates and a radiation X-ray. It's nothing but a form of specialized X-ray, and this is the kind of image which we get. There usually two views are taken: the craniocaudal and the mediolateral oblique, and depending on that, the reporting is done. The mammography is reported classically by what is called the BIDADS classification, which you can see here. It's available anyway, so you can go through it later. Basically, what we need to realize is 4 and 5, the 4, 5, 6 are usually the ones which are very high for malignancy, and any patient who reports with a BIRADS grade 4 onwards should always be investigated and treated as a malignancy unless proved otherwise. The mammography, as I said, is usually the first and the most important step for diagnosis of a breast cancer. But there are certain patients where mammography is not helpful or mammography cannot be done. So that is where sonography becomes a good tool. Also note that nowadays plain mammography is usually not done. All mammographies are supplemented with a sonography of the breast. That is why you must have heard it's now called as the mammosonography. A plain mammography usually is not done. It's always a combination of mammography and sonography, and the mammosono report is what we follow. But in certain cases, a mammography is not done or not helpful. In that case, even a plain sonography is good enough. Usually young women less than 35 years, they have a bulky breast and a dense breast. And also, as we discussed, we don't want to expose them to unnecessary radiation. So in those cases where there is a low risk of malignancy, they don't have any risk factors, a simple sonography is good enough. We need not advise a mammography to a 25-year-old woman with a very small lump in the breast, which you know can be a fibroadenoma or a cyst. So the first investigation in those cases is better to do a sonography. Of course, if there's anything doubtful, we can go ahead and get the mammography done. Another important use of the sonography is for these follow-up. Like a patient comes to you for the first time, you get a sonography and there is a lesion which is doubtful. You can always wait for a month or 2 months and get a follow-up sonography, and accordingly decide if the disease is progressing. You can get a mammography and investigate further. If it is static or resolved, then you can leave it as it is. The next important one is the MRI. This, of course, again is even highly more specialized, and because of the cost and availability is not advised to everyone. Please note that breast MRI is not just getting an MRI done like you would do an MRI for the abdomen or the brain. A breast MRI, a classical breast MRI, requires a special machine, which is special breast dome, which you can see here. The patient lies prone and the breast falls into a coil, a magnetic coil, and the breast images are generated like this. But of course, the availability of this is limited. So in absence of this, we go ahead with the general breast MRI. But the ideal one, of course, would be an MRI with a dedicated MRI breast coil. So in whom are this MRI recommended? Of course, they are done in the very high risk patients, because MRI has very high sensitivity and specificity, and so Those who have a very high chance of developing a breast cancer, especially in the young ages, like the genetic ones like BRCA1 2 positive and their family members, the patients who have had previous radiation to the breast earlier. So we don't want to add to the radiation exposure. So in those cases, again, MRI is good. And of course, certain syndromes and genetic things. Other indications would be an occult primary with a axial lymph node. Sometimes the primary in the breast is so small, or maybe the breast is so bulky and dense that we are unable to palpate, or the mammography is unable to detect the lesion. In these cases, MRI is very helpful and can help us get the diagnosis of a breast lump. Similarly, in scars and recurrences, it's a very useful tool to differentiate between a scar of a previous surgery. Maybe a plain lumpectomy was done, and then this patient comes back with a thickening or a lump in the same area. So MRI can help us differentiate between a scar and a recurrence. Also nowadays, with many females opting for breast implants for breast augmentation, this does help to detect the disease. Sometimes the implant hinders the imaging and you cannot detect. In those cases, we can go for an MRI. The next part, of course, is the tissue diagnosis as well, the pathology part. So the pathology can be done in various forms, either by a small fine needle, which is just put, and only the cells are aspirated, and they are put under the slide, what we call the fine needle aspiration cytology. Sometimes, if the lump is small or it's a diffuse lump, or the needle does not hit the proper area while doing the FNAC, we may get an inconclusive response. Or maybe sometimes in a DCIS patient with in situ carcinoma, we may get some abnormal cells, but it's not enough to label it as a carcinoma. In those cases, what is preferred is, of course, a core biopsy. A core biopsy is nothing but a bigger needle which is inserted into the lump, and a bigger piece of tissue is taken out, and then it is subjected for biopsy. And so it gives us a more comprehensive. In FNAC, you get to see only the cells. In a core biopsy, you can see the entire tissue. You can see the duct, the alveolus, the membranes, and so of course it's a better indication, better sample for diagnosing a cancer. But again, sometimes again, as I told you, in very diffuse lesions, it may not be possible to hit the exact part with the needle. So in those cases, we can even go for a excision biopsy. That is nothing but we remove the whole lump and send for biopsy. And depending on the report, we proceed further. If it is a benign report, we can let it be. And if it's a malignancy, we stage the disease and treat further. Other modalities of treatment of diagnosis, which of course is more for staging of the disease. As we said, the clinical examination, radiology, and pathology. The triple assessment was for initial diagnosis, but any cancer needs to be staged, and the staging is for that we require the other investigations. For very early breast cancers, staging chest X-ray and ultrasonography of the abdomen and pelvis is more than enough. But nowadays, with the easy availability of the CT scan, most of the clinicians, they prefer to get a CT scan of the thorax, abdomen, and pelvis, so that we can look for the lungs, basically liver and the ovaries. The common places where you would suspect a breast malignancy to metastasize would be the lungs, livers, and the ovaries, which are also known as the Krukenberg's tumor. So CT scan is usually enough. PET scan, if you're aware, it's a special kind of CT scan where we put radioactive label fluoride into the patient, and that is picked up by the PET scan machine and gives an image of the whole body with the FDG avid, the radioactive fluoride being picked up selectively by the malignant cells. So what you get is an image of the places where the malignant cells are available. So this is again a better tool for detecting the metastasis. But again, unfortunately, because of the availability, it is being used more nowadays. But what is recommended is usually used for stage 3 and stage 3 diseases, PET scan could be done. For early stage 1 and stage 2, a simple sonography with chest X-ray or a CT scan suffice and need not be done. If a PET scan is not available and a patient has a locally advanced disease with bone pains or an elevated alkaline phosphatase level. Even a bone scan is handy many times because, as we discussed, skeletal mets is very common in advanced breast cancers. So sometimes the CT scan is unable to detect these changes because they may be very small lesions and very small difference in the change in the intensity on CT. In those cases, a bone scan helps, especially if there is a bone pain somewhere and an elevated alkaline phosphatase levels, and a PET scan is not available. We can do a bone scan and complete our staging workup. So having done all these investigations and diagnosis, we go further and we do staging of the disease. Staging, the current staging, what the oncologists follow are the AJCC edition 8, 8th edition of AJCC, which is the one which is displayed here on the screen. Without going into details, what we need to remember is stage 1, T1 is less than 2 centimeter, T2 2 to 5 centimeter, T3 is more than 5 centimeter, and T4 is the one where it is further divided into A, B, C, and D. A is when it affects the chest wall. Chest wall is uh, defined classically as the serratus anterior, intercostal muscles, or the ribs. So adherence to any three of these makes it a T4A. Pectoralis major does not qualify as a T4 disease. The invasion of only the pectoralis major is not considered a T4. A classical chest wall would include the involvement of serratus anterior, intercostal, or the ribs. T4B again is the involvement of the chest. Like T4A was posterior involvement, T4B is anterior involvement. So involvement of the skin or nippleareolar complex with pudiorange fungation, ulceration comes as T4. Combination of both is T4C, and an inflammatory carcinoma is T4D. For the nodal classification, again, without going into all the details, we need to remember T1 is only the axillary lymph nodes, the outer level 1-2 lymph nodes, and which are mobile. A fixed lymph node, usually a nodal mass, goes into N2, and N3 is when it goes up to the infraclavicular or the infra and supraclavicular deep nodes. So based on this TNM, again, the staging is done. Very frankly, it's a very detailed staging, which is impossible for anyone to remember. So even all us oncologists, we have these stagings in our mobiles, which we can always refer to. But what we need to remember in this staging is the points where the treatment changes. So grossly, it is important to remember that the moment the macroscopic nodal positivity comes, N1, it becomes a stage 2 disease, right? So in general, to remember a node, T1 disease without nodes can be stage 1. This is what we call the early breast cancer. Then comes the node positive breast diseases, which can be the called locally advanced advanced breast cancer. And then comes the locally advanced breast cancer, where you have the N2 disease. N2, as I told you, is nothing but a fixed axillary nodal mass. So once the nodal mass also start getting fixed, it becomes a locally advanced disease. In general, the division of treatments lies in between. Stage 1 and 2, we usually subject to primary surgery followed by adjuvant therapy. And stage 3 onwards, it's usually an adjuvant chemotherapy or adjuvant hormone therapy, targeted therapy, followed by surgery. Of course, there are certain gray areas, what is called the operable LABC or the operable locally advanced disease, which classically involves the T3N1, where the nodal disease is not very heavy, but the primary tumor is big. But still, if it is resectable, then some cases of T3N1, they are considered in the surgical category. And of course, it's a case-to-case basis decision. The importance of staging, so you can understand from this, is how to plan the treatment. The treatment of breast cancer, as will come, is a multimodality treatment. It involves surgery, chemotherapy, radiation, hormone therapy. So which permutation combination and how to use it, which modality to use first, which next, that is defined by the what stage the patient is in. So that is why the staging is important. Going further, now let's discuss about the treatment. Treatment, of course, of breast cancer is a very extensive topic, and we will not be able to go into details of everything. So let us just try and understand the basic modalities of treatment what we have. Like the government has the Army, Navy, and the Air Force to fight their battles. We have these three: the medical, surgical, and the radiotherapy. These are our Army, Navy, and Air Force to fight any cancer in general, and especially in breast cancer, where it's a multimodality treatment. Medical management is basically nothing but chemotherapy, what is classically known as the chemotherapy. And now, with advent of newer agents like hormonal therapies and targeted therapies, which we will discuss later, surgery has always historically been considered the primary treatment for all malignancies. To remove the disease is most important, to remove the disease from the body, and then whatever the microscopic disease which cannot be seen, we deal with the medical or the radiation therapy. But as I told you, depending on the stage, it may not always be helpful to operate first. The surgery may not always be the first line of treatment for all breast cancers, but of course, it is always a part of the treatment. Surgery again, MRM or the modified radical mastectomy is the classical surgery that has been done since decades now. But with advancement of diagnosis, advancement of better chemotherapies and better surgical techniques, we can now even conserve the breast and do a lot of reconstructions and oncoplastic surgeries, which of course we'll see a little later. Radiation therapy, again, it's a another adjuvant for us. If the disease load is high, if there is involvement of the chest wall, a lot of lymph nodes are involved. The radiotherapy helps us sterilize the local field. The cells which we cannot see, the microscopic seeding which may have occurred in the neighboring area, in the loco-regional area, can easily be sterilized by radiotherapy, and thus it helps in the treatment. So now we'll see the various arms of treatment in little detail. First, of course, surgery for the primary, which could be a MRM or a conservative surgery. The BCS is nothing but a breast conservative surgery. Like I told you, nowadays we need not remove the whole breast because certain females, rather most of the females, now they're conscious of their image, of the cosmetic outcome, and they do not want to lose a very important part of their body. So what we can do is just remove the lump, the breast cancerous lump with adequate margins, and do a lymph node dissection, and the breast can be conserved. The conserved breast, of course, then needs to be reconstructed. Sometimes, if the lump is small and the breast is large, you may need not do a reconstruction. But most of the times, the defect is big, and we need to do a reconstruction. That is basically what we call the plastic surgery. So, various kind of flaps, like the LD flap, latissimus dorsi flap, TRAM is the transverse abdominis rectus muscle flap, and the DIEP flap. These are the various flaps which can be done in a pedicle fashion and also by microvascular or free flap surgeries. And then the oncoplastic surgery, which are nothing but mobilization of the remaining breast tissue to cover the defect of the breast and to give a shape to the breast, which I'll show you the images in a little while. And next comes is the metastatictomy. Traditionally, it was always said a stage 4 or a metastatic disease is incurable and they should not be subjected to surgeries, and they should be allowed to die in peace. But with good chemotherapies, good targeted therapies, we are able to control the disease in such a manner that sometimes what we are left with after chemotherapy is a very limited metastatic disease, which is also called oligometastatic disease. Oligometastatic disease is a metastatic disease limited to just one organ, maybe a single bone, single lesion in the liver, a single lesion in the lungs. So if all other factors are favorable and the patient has a high chance of survival, then we can even subject them to metastatictomy, and oligomets can be removed and improve the survival of the patient. Medical therapy, of course, is a systemic therapy. That is, the breast carcinoma is known to be a metastatic disease to start with. It is said any lump, a cancerous lump in the breast, which is more than 1 centimeter, starts metastasizing at some point or the other. So we do not know where those cells could have gone and seeded and at what stage. So that is why we require the systemic therapy to cover all the microscopic disease that could have spread to the body and which can be controlled by this therapy. The most frequently used, the most commonly used drugs of chemotherapy for the breast are the anthracycline-based ones, especially the adriamycin or doxorubicin, the Taxols, namely paclitaxel and docetaxel, cyclophosphamide, and 5-fluorouracil. They are used in different permutations and combinations depending on the side effect, the adverse reaction profile, the general condition of the patient, and the body weight, and the various prognostic factors and markers which we saw earlier. So depending on that, usually at least 2 or 3 drugs combinations are given and the chemotherapy regimens are planned. The next one is the hormonal therapy. Here comes the importance of the ERPR receptors that we had discussed in the pathology segment. ERPR positive patients respond very well to the SERMs, or the selective estrogen receptor modulators, the tamoxifen and raloxifene. They can be given for 5 years or nowadays even up to 10 years post completion of surgery and chemotherapy. And they have found to be very effective in improving the survival and also prevent the recurrence. In post-menopausal patients, of course, the tamoxifen are not that helpful. So in those patients, the aromatase inhibitors, namely anastrozole and the newest drug letrozole, are used with the same effects. The next group of systemic therapies, of course, the targeted therapies. These are nothing but monoclonal antibodies which are produced against the various antigens or receptors present on the cancerous cells. The most commonly used one is trastuzumab, or the common trade name what is used is the Herceptin, which you might have heard. It is nothing but an anti-HER2/neu antibody, monoclonal antibody, and it also has the same role of preventing recurrence and improving survival. The other ones, the pertuzumab, neratinib, lapatinib, they all are also targeted therapies, but their role is not proven in non-metastatic disease. They are usually given in the non-metastatic disease for prevention of progression. The last three, if you see, these targeted therapies are still not used as a curative modality. They're used in palliative end-stage diseases to prevent the progression of the disease. The next modality is, of course, the radiotherapy. Radiotherapy is nothing but a CT scan-like machine where the patient is put in and the radiation is given. This, of course, is an image of a head and neck radiation being given, but the principle remains the same. An external beam is focused onto the area. You can see here on a CT scan, they plan out the area which is given to be given radiation. And with the precision available with today's machines, you can pinpoint your radiation to the part where the tumor is and thus decrease the side effect to the surrounding tissue. Right? So even the underlying heart, lungs, and everything can be spared, and all your energy can be focused only to the tumor bed. Still further modification of this are the brachytherapy, where the radiation is given directly into the tumor bed. Again, the advantage being to decrease the side effects to the surrounding tissue. The various forms of brachytherapy available are, of course, these are tubes which are placed in the tumor bed during surgery, and then radioactive source like this, which usually contains a cesium isotope. A radioactive source is inserted where it goes to the tumor bed and radiates the local area. This is another form of a brachytherapy. This device is called a mammocyte, which is something like a Foley's catheter if you see. So it is an inflatable balloon. So once you have done a lumpectomy, you can put this there and inflate the balloon so that involves the cavity, it occupies the cavity. And then usually after 48 hours, it is attached to this machine and a high dose is delivered locally, thus sterilizing the surrounding area of any residual cancerous cells, and at the same time sparing the side effects to the skin and soft tissue and the axilla. I guess that is what we have of the grossly about the treatment. Now, as I told you, I would like to show you some of the recent surgeries that we do to help conserve the breast. So this you can see is only the lumpectomy has been done, but of course the breast shape has changed drastically. So what is done is the fat is taken from the abdomen like a liposuction, and then it is injected into the breast. And this is an immediate post-op picture. And after 2 months, this is how this is the same patient with the same results. So nowadays it is not required to remove the whole breast. We can easily remove the lump, treat the patient with the axillary clearance, and still give a very good cosmetic result. Similarly, this is again where we have removed the axilla nodes and the lump has been removed. And this is the latissimus dorsi muscle. The latissimus dorsi muscle is taken and then it is put and plugged into the hole. And this you can see again the shape is restored. For a bigger defect, of course, that will not help like we see in this one. So in those cases, a tram flap, what we discussed, the transverse abdominis flap, which is taken from the abdomen. You can see here a scar from the abdomen. It is taken and then it is placed on the breast. So you can see very good cosmetic results, and the patient does not have to live with the absence of one breast for the rest of her life. Similar picture as you can see is there, a huge defect is formed. So again, the transverse abdominis is taken and the breast is, of course, this is a first stage surgery. It requires further modifications and augmentations and nipple reconstruction. And of course, if sometimes if the bulk, it's only the bulk is the issue, then implants can be placed. The skin sparing mastectomies, as we call, we can preserve the skin, remove the breast tissue, and then put implants inside, which helps increase the bulk and gives a proper result. Thank you. That's, I think, a broad outline of all the aspects of breast malignancy. Thank you all for joining us. If you have any queries, I think you can mail it and we can get back to you, or maybe once we start with the classes, we can arrange a similar lecture again where we can solve your queries.